may show up as one of the wrong answers, you'll know what it is. Still though, it's, you know, I have a finite amount of time to get as many things in here as possible, so we'll get started here. All right, so we're going to start proximal, and obviously we'll start with the esophagus. And the idea of this slide is just to give you the anatomical reference of the esophagus. Obviously starts with the epiglottis and works its way down to the lower esophageal sphincter. That is a PA representation of the esophagus. The important parts about this are notice its orientation and notice its muscular orientation. We'll get into that a little bit more in a little bit. But notice the outer layers are longitudinal of that. And if I had a laser pointer at the bottom, when you see that trim section of the esophagus, you'll see the inner layers are circular in that. That's important because those two parts, those two orientations of muscle are what drive peristalsis, or movement of the esophagus. So if you think about these things, you don't have to memorize them, just think about them, they'll make sense. That is how this works. So outer layer longitudinal, inner layer is circular. The upper 2/3 is mainly striated muscle. The lower 1/3 is usually smooth muscle, more smooth muscle. So diseases that affect striated muscle, polymyositis and things like that, will affect the upper 2/3 more. Diseases that affect smooth muscle, like sarcoid, things like that, will affect the lower 1/3. So it fits anatomically and pathophysiologically with its anatomy. All right, here's a lateral representation. The important part about this is notice that little pearl wrap just subdiaphragmatically. That is part of the lower esophageal sphincter. We'll really get into that in a minute. That has everything to do with reflux esophagitis, and so we'll talk about that, but just notice where that is. All right, so first, starting with esophagitis, remember that itis does not mean infection. Itis is inflammation. Infection can cause inflammation, but it is not infection by itself. So esophagitis are either infectious or they're inflammatory, and we'll talk about the common ones of those. In general, they occur principally in immunocompromised patients, and that doesn't mean they have AIDS. You can be immunocompromised if you have cancer, if you're on chemotherapy, if you're on a Medrol dose pack, if you're on any of the biologics for rheumatoid or psoriasis. That is ostensibly an immunocompromised state, so esophagitis occur there. The infectious esophagitis is most common are the Candida, the herpes, and the CMV. That Candida occurs commonly in people that are not terribly immunocompromised. It happens in babies after antibiotic therapy. Happens when you give somebody Medrol dose packs for poison ivy, but you get candidiasis of the mouth and the esophagus, so that's thrush. Think about that. Herpes simplex and CMV, that's where you get into the chemotherapy patients, the HIV patients and such. Clinical manifestations, painful swallowing, that can be severe. These people will stop eating altogether. Babies won't feed, they won't go to the breast, they won't drink from the bottom. And then dysphagia, weight loss, upper GI symptoms of bleeding are common. Obviously, if your esophagus is inflamed, your mouth is inflamed, you're not going to want to eat, it'll hurt to swallow. The herpes esophagitis is associated with oral lesions, and candidal esophagitis is obviously associated with thrush, or oral thrush. That is oral candidiasis. That is not strep. When you look in somebody's mouth, strep is on the posterior lateral pillars, not so much on the soft and hard palate. It is not little white dots, candidiasis, it's those painted areas there. All right, so what are we going to do? Candida esophagitis, oral nystatin and clotrimazole, that works well if you're not talking about the HIV patients or severely immunocompromised patients. If you are, we're talking about fluconazole and the HIV patients. Sometimes you can go to foscarnet, but mainly fluconazole works well there. Herpes esophagitis and CMV, both oral acyclovir and or ganciclovir. So the treatment's fairly simple. Now here's the inflammatory esophagitis, like we talked about. It's not always infection. So this is inflammatory. This is the most common inflammatory esophagitis, and it occurs from radiation during chemotherapy. Happens usually above 3,000 centigrade. That's an amount of radiation absorbed by the tissues. This can get really severe. So these folks get terrible pain with swallowing, they get terrible oral ulcers, they get terrible esophageal ulcers, and most of these people will lose weight. Some of them will get very cachectic and anorectic. You have to stop your chemotherapy, you have to stop the radiation, commonly put in a peg tube, sometimes give them parenteral nutrition other ways. Key is you got to weigh the risk and benefit of stopping your treatment, whether it's chemotherapy or radiation, versus trying to get them fed and keeping them alive. So symptomatic treatment's key here. Now let's talk about esophageal motility. Simple slide. The idea is if you understand motility, you'll understand some of these other disorders of that motility. So what is normal motility? We got to understand again, tubular smooth muscle structure, it's striated and smooth. The outer layer is longitudinal, inner layer is circular. If it's driven correctly, it's all under vagal control. If it's driven correctly, you'll get contractions at the right area, you'll get dilations at the right area. Things will move proximal to distal, and that is normal peristalsis. So anything that disrupts that gives you esophageal motility disorders. All right, so this is kind of a terrible slide, but the idea is down the left side is length of the esophagus proximal to distal. Across the bottom is time. So you can see the contraction there that's moving temporally left to right from proximal to distal. And that's the idea of normal peristalsis. Previous slide showed vagal control. That's the key to this whole thing. Anything that messes up vagal stimulation or vagal function, esophageal motility disorders can come about. Right, so there's the vagus nerve. Busy slide, don't have to memorize it. You already did that in Dan's lecture, the neuroanatomy lecture. The idea is hip cranial nerve comes out of the distal medulla there on the lateral aspect, and it drives the GI tract. Here's another representation of the same thing. So if we have anything that messes with that vagal function, we get motor disorders of the esophagus. Now, in general, they're divided two ways. There's oropharyngeal, which is obvious, and esophageal. Oropharyngeal is really all about the discoordination, because it's disconnected, the discoordination of moving a bolus of food from the anterior mouth to the posterior mouth and down into the proximal esophagus. And if you think about it, that's an incredibly coordinated event. So anything that disrupts that, things like Parkinson's disease, neuromuscular disorders, MS, they cause oropharyngeal dysphagia. So how do we tell? The modified barium swallow, which I have a pointer here, but modified barium swallow, notice that's in yellow. And I've done that. I kind of tell you about things, how do we diagnose it, how do we treat it, and that's the way the test questions are set up. But anyway, modified barium swallow is how we can tell if these people reflux it or they can't get it into the esophagus, or worse yet, they send it down the trachea. You know they've got esophageal motility disorders, they've got dysphagia. Okay, now let's go to the esophageal type. And the three most common are achalasia, diffuse esophageal spasm, and nutcracker esophagus. So those three pop up on tests and on board exams. So achalasia first. That's the most common esophageal motility disorder. It's kind of an interesting disorder. We're not sure exactly why it happens, but the statement in yellow is the key statement. And that is that vagal problems, you lose the vagal dorsal motor neurons, you lose the ganglion cells in the wall of the esophagus, but that leads to an increase in the lower esophageal sphincter tone. In other words, the lower esophageal sphincter is slammed tight and won't relax. And then the body of the esophagus is completely dilated. It has no drive for peristalsis. So you get a wide dilated body of the esophagus, and the door of the lower esophageal sphincter is slammed shut, and you get your symptoms. So chest pain, regurgitation. These people will eat and they'll stop at the table and hold their chest. They do it again and again. There's somebody in this room, I guarantee, that's done this, or knows somebody that has. And then later they have to excuse themselves from the table and go throw up to clear it. Eventually, the lower esophageal sphincter will open up and they'll get food through. But sometimes you have to use medicines and things like that. So barium swallow again shows the dilated body and the way too tightly closed lower esophageal sphincter. That is kind of representation of this. And there's a picture of it. So that esophageal body there obviously is way too wide. That's a barium swallow. And notice that it's just tight. It's just barely getting through what they call the bird beak appearance of the LES. And these folks, to treat it, back here, you can use muscle relaxants, you can use nitrates, you can use nifedipine, things that calm down smooth muscle contractions. Well, you'll learn a little bit later on that those very same medicines, those very same treatments can over-relax the LES and cause reflux. That causes esophagitis. So you're kind of walking a fence here. All right, now let's compare and contrast this to diffuse esophageal spasm. And by the way, I want to make a point here. This is an aperistaltic disorder, meaning there is no movement proximal to distal. So this is aperistaltic. Now we go to diffuse esophageal spasm. It is exactly what the name suggests. It is a diffuse spasm. It is not temporal. It's aperistaltic again. There's no peristalsis. In yellow, non-propulsory. It's a common disorder. It's kicked off by the swallow itself, chest pain, dysphagia, or both. It gives a corkscrew appearance of the esophagus on barium swallow. So that's kind of its pathognomonic finding. Treatment, supportive. It's empiric. Calm these people down. They commonly come to the ER thinking they're having a heart attack. Smooth muscle relaxants, again, can help you. Believe it or not, antidepressants, the tricyclic antidepressants have some pretty good data on calming some of these people down. Happens in people who have anxiety, people who are amped up, type A people more often. And then biofeedback's really impressive. But if you have somebody that's swallowing disorder, sending them to a psychotherapist, they never go. All right, so here's diffuse esophageal spasm. Notice on the right, on the manometry, that's a random series of contractions. And, well, this one doesn't have, we have does have the numbers. On the right side of the manometry, notice those contractions are 0 to about 60 millimeters of mercury. Normal is 0 to 40. So some of these are mildly high amplitude, but usually not too high amplitude. But the key is they're random and they're aperistaltic, right? That is the bird, sorry, that's the corkscrew appearance. Now let's talk about nutcracker esophagus, okay? This, by contrast, is a peristaltic esophageal motility disorder. This does move things proximal to distal. It is characterized by very high amplitude contractions, so 200 millimeters of mercury or higher. Now remember that viscous structures, round and tubular structures, you can cut them all day and you can't feel it. They have no nerves of pain when you cut them. They only feel being pinched or constricted and being stretched. So anytime you stretch a ureter with a kidney stone, or you dilate an esophagus, or you're constipated, it hurts. And that's the only sensation tubular structures have. So if you have an incredibly strong contraction, people will sometimes swallow, pass out. It causes a vagal response that's so painful. Again, characterized by high amplitude contractions, it gives you chest pain without dysphagia. Things move down. They can follow their food all the way down. They can tell you right where their swallow is, but they don't regurgitate because it is peristaltic. So what's the treatment? Again, muscle relaxants, nitrates, reassurance you're okay, it's not a heart attack. And again, biofeedback is effective here. This is also, as you see in the symptoms, it happens more in people with anxiety, people that are manic depressive in the manic state. And so it's thought that adrenaline plays a role in this. Yes?
Would it go away by itself if, say, someone didn't go to the emergency room?
Yes, it calms over time. But remember, the swallow is the trigger. So if you keep eating, you'll keep firing it out. Keep firing it. If you can just get calm, get laid down, usually it goes by itself. Okay, so high amplitude contractions. Higher than 200 millimeters of mercury. In some cases, these people really hurt. It's obvious that they're hurting, holding their chest. Okay, Mallory Weiss here. This is another topic that we're off the esophageal motility disorders because this one, you can see on symptoms down at the bottom, but occasionally it can be so strong. If you have a big bolus of food, you can tear the lining of the esophagus. So that's where we get into Mallory Weiss tear. That is called a Mallory Weiss tear. And what is that? It is a mucosal only tear within the esophagus. It's small, it's usually down distal at the esophageal gastric junction. It happens more in middle-aged male. They always present with throwing up blood, hematemesis. It doesn't hurt that bad, but it scares them to death. It can happen after people that have gastritis. They throw up 20 or 30 times, all of a sudden the last time they have some blood in it, they freak out. That's a Mallory Weiss tear. This is what it looks like. Tiny little longitudinal tears. Notice they're not complete thickness. They're just in the mucosal layer there, but they bleed. And if it's in somebody who's an alcoholic or cirrhotic liver disease at all, they have mild portal hypertension, which we'll talk about in a little bit. And if you have portal hypertension and you rip into that muscularis layer or just below that, the proprial layer, that's where the vessels are, and you can bleed a lot. Okay, so what's the treatment? Most of these tears heal on their own. The esophagus is much like the palm or sole of your feet. It heals quickly. It takes a lot of abuse, and it heals quickly. So if you give it time, these bleeds will commonly stop on their own and heal. But you gotta wonder, am I still bleeding? You don't know. You didn't feel it when you got it. You know you were bleeding last time you threw up. You don't feel like you need to throw up, but I gotta know. So most of these people end up with an EGD in the ER, and they watch it and see if it's still bleeding. They'll do serial CBCs and make sure that they're not dropping their H&H. But the idea is they'll call them on their own the majority of the time. Now, complications, you can rebleed. If you're on aspirin, if you're on blood thinner, if you're on factor 10, if you have heart disease, all these things, liver disease, you have to watch your rebleeding. And the most worrisome one is extension. So if you have an alcoholic that continues to drink, somebody on antabuse, things like that, and they continue to vomit, they can rip right on through. That's called a Boerhaav's tear. Boerhaav's tear is a full thickness tear. That's bad. You're essentially swallowing out into your mediastinum or into your epigastrium. That's bad. Okay, switching topics. They love this topic on tests. They love this topic on board exams. Nothing to memorize here. If you all understand it, it's really a simple pathophysiologic system, so if you understand this, you'll understand gastritis, so we'll move through it relatively quickly. So there is a representation of a normal swallow. Obviously that's peristalsis. You swallow, upper esophageal sphincter relaxes. The esophageal body then has a contraction, again 0 to about 45 millimeters of mercury that works temporally, proximal to distal. And you look at the bottom of the lower esophageal sphincter, which has a resting tone. That's the key. The lower esophageal sphincter has a resting tone. It will be told by the vagal stimulation to relax. The bolus drops in the stomach. It tightly closes. The stomach starts ruminating. You'll see in that bottom line that the resting tone of the lower esophageal sphincter remains. That's the key, is the LES resting tone. Now, if you lose that, weak lower esophageal sphincter, this is representation of a chronically weak lower esophageal sphincter. These are post-stroke. These are vagal nerve disorders. These are any of the disorders that give you a chronically low lower esophageal sphincter pressure. And you see every time that stomach ruminates, just a little bit of squeezing, the pH line goes up and down, up and down. So the pH is dropping because of small squirts of acid. So that is chronically low lower esophageal sphincter tone. Now that is compared or contrasted to transient relaxation. This one is in people who take nifedipine, any non-dihydropyridine calcium channel blocker, eat a lot of chocolate, eat a lot of peppermint, on asthma medicines. All of those things directly relax smooth muscles. Remember we talked about those were some of the fixes for achalasia earlier, but here, if you take those medicines because you have hypertension or you love chocolate, you'll relax that lower esophageal sphincter and you'll get GERD or reflux disease. And you can follow it. Whenever that lower esophageal sphincter relaxes on the bottom line, the pH drops. That means acid got squirted up. So the question is, which is more common? Simple slide, it's transient. Obviously, transient is because of medicines and food, what we just talked about. Just kind of start that page. All right, so what do we do about GERD? You know, this slide goes way back to, I love this slide only because it's taken us from, you know, the 1980s to now. But we used to use antacids, alginic acids, sucralfate. They really didn't do much. They're a base. They reverse the acidity of it. It's a symptom reliever, but it doesn't fix the irritation that's going on. Go all the way to the right side there, methanicol, metoclopramide, cisapride, those are pro-motility agents. The idea there is, if I make the esophagus squeeze and have a tertiary contraction to clear, then I get rid of the acid and we win the battle. Well, worked well for symptoms, did not do very well for endoscopic kind of healing, because they can take a biopsy and see if you're healing the problems. And the bad thing was all three of those have a secondary side effect of QT prolongation and death. That's a bad side effect of medicine. So they pulled those off the market. So the middle segment's where we go. We start with the H2 blockers, Zantac, Tagamet, that's cimetidine, ranitidine. They work well. They have both endoscopic improvement, they have symptom relief. And then we invented the proton pump inhibitors. That is the key to this whole slide, PPIs. That's the mainstay of treatment, gold standard. It is both diagnostic and therapeutic. So if you think, I think this is an acid-related disorder, I think this is GERD, can't prove it yet, put them on a PPI. If they say 3 days later, I was symptom-free, well, you've not diagnosed it. That was an acid-related disorder, and you're going to heal them. So that's the same thing. There's the comparative slide telling which works best. Yellow, obviously, is the PPI. Just know that the most symptomatically improving and endoscopic improving medicine are the PPIs. All right, you're not going to be tested on histology, so don't worry about that. This is so you understand what goes on. So that's a slide of stratified squamous epithelium. I think you all had some histology, but notice the cells each have one nucleus per cell. The cells are stacked and they're flat. That's skin the palm of your hand. That is your esophageal mucosa at the upper 2/3, but that is still stratified squamous epithelium. That is as opposed to this. Now, when you irritate stratified squamous epithelium, just like working hard, something rubbing your hands all the time, you begin to thicken the skin, a callus. That's what happens here. Those cells are no longer flat, they're cuboid, they're square, they still have one nucleus per cell. Those papillae, those little dips in there are getting a little bit taller, and those cells are kind of mounding up. So this would be just like a callus on the palm of your hand. If you continue to irritate, and we're talking about the esophagus, if you continue to dump acid, pepsins, bile acids up into the distal esophagus, your body will continue to try and protect itself. and you get this. Now, these are columnar cells. We've gone from the cuboid over to columnar. Notice there's still one nucleus per cell. There's small vacuoles being made. The papillae are getting deeper. They're still relatively well organized. Now, the problem is, when we see this in the esophagus, this is called Barrett's esophagus. And that's key. You'll see that again on tests. You'll see that again on boards. But Barrett's esophagus is important because it is a non-cancerous squamous metaplasia. So this would be like an ascus pap. That's what an ascus pap looks like. But non-cancerous squamous metaplasia of the esophagus. It is the last step prior to becoming cancerous, esophageal cancer. So when you have Barrett's esophagus, or you have a patient with that, you must get aggressive with treatment. They're on PPIs probably twice a day, every day. They got to stay on that for years. If you don't stop them there, we get this. Notice that's random arrangement. You have multiple clumped nuclei per cell. You have crypts, you have crypt abscesses, you have bleeding in there. That's bad. That is esophageal cancer. It's a bad player. 5-year survivability is less than 5%. Okay, so that'll segue into the neoplasm of the esophagus. In general, they predominantly affect people between 50 and 70 years of age. There's really two types. There's adenocarcinomas and squamous cells. If you guys, I'm sure you've figured this out and been taught this, but if a cell produces something, if it turns cancerous, it's an adenocarcinoma. If it has a production. If it is just a squamous or a covering cell, then it's a squamous cell cancer. So we talked about the upper 2/3 is mainly squamous cells, the lower 1/3 is the cuboid cells. So you get adenocarcinoma in the lower part of the esophagus, you get squamous cell carcinoma in the upper part, mid part. The associations there, notice adenocarcinoma, Barrett's esophagus. We just saw that. Distal esophagus associated with Barrett's esophagus, that's adenocarcinoma. Squamous cell, smoking, alcohol, achalasia, which is a constant irritation to that area. It produces a constant irritation. Those are kind of predisposing factors. We'll talk about some of those in a second. So clinical manifestations, you get dysphagia. First, you have a hard time swallowing solids. That's because the thickness of the esophagus, it loses its distensibility and foods get stuck. That eventually progresses to, I can't even get liquids down. That's a bad sign. When you start getting weight loss and anorexia, you're usually in stage 3 and you're in trouble. So if we talk about predisposing conditions, we'll do associations and conditions. This you don't have to memorize, but just understand. For squamous cell carcinoma, the commonality of all of those is their irritants. Achalasia, celiac sprue, Strictures, Plummer-Vinson syndrome, all those things. Tylosis, it's an acid, it's actually a base that burns your esophagus. But all of those have to do with irritants. So squamous cell carcinoma is really connected with irritants. And then the predisposing factor for adenocarcinoma is Barrett's. It's the third time I've shown that. That must mean something. So proposed risk factors. The mnemonic is cancers. These all go without saying. Cigarette smoking, obviously. Alcoholism, obviously. Nutritional deficiencies are vitamin A and zinc. Carcinogens, they're talking about nitrosamines in bacon and in charred meats. Endemic organisms, HPV. That is what that's about. We know that wherever there's HPV, there is cancer, squamous cell cancer. And regional practices are talking about drinking really hot liquids. In the Far East, they drink near boiling tea every day. They have 3 times the risk of esophageal cancer. Soil salinity, that's not really ferreting out much. Right, so there's an esophageal cancer. That's an ultrasound on the bottom. That's clearly the EGD on top. You don't want that. You want to reverse this, Barrett's esophagus, before you get that. Okay, so let's talk about strictures. New topic. Strictures are just what they sound like. They can be webs, rings, or diverticula. The webs and rings are intraesophageal. The diverticula are kind of outpouching on the outside of the esophagus. The cervical esophageal webs are commonly found in Plummer-Vinson syndrome. That association is, I've seen that once on a board exam as a wrong answer, so just so you know that. Major complaint is solid food dysphagia. Obviously, if there's a web, it looks just like a spider web going across, or you have a stricture pinching it down, things get stuck. So it's common in people. Plummer-Vinson syndrome also has type A enteral gastritis, which is associated with iron deficiency anemia. So people that have iron deficiency anemia commonly have strictures and webs and things. It's just association, it's not a cause and effect. The EGD is the study of choice. E.g., obviously, if we can stick a camera down there and we see this stricture or we see a web, we know we've got a problem there. That's a web. It's easily ruptured. You just take the EGD scope and push it right on through. That's half the lumen you're looking at. And that's commonly what they do. They say, oh, they had a web, we've ruptured it, and they do well until it regrows. They do reoccur. So, strictures. What are strictures? Again, that's a circumferential ring, usually of a scar. It's not external, but it's in the external edge of the esophagus, and it squeezes down. What is it from? These things are usually irritant-driven, meaning if people have chronic reflux, the burn causes a scar in the esophagus circumferentially. The esophagus is distensible unless you have a scar. Scar doesn't stretch. So everything moves down until it hits a scar and it stops. So that makes sense that strictures because of chronic reflux occur. And then a Zinker's diverticulum. They love this on the boards. It is an outpouching. It kills dehiscence. I'll show you a picture. Many people are asymptomatic. It's just a little outpouching that traps food up high in the cricothyroid behind it. People will eat a meal and say, gosh, 6 hours later, I coughed. What a big cough. And I had completely undigested salad or whatever I ate, just sitting there dry. And so you do an EGD, you look at it, and you surgically fix it. That's a picture of the production of one right Achilles dehiscence, posterior right behind the cricothyroid. There's another representation of the same thing. So Zinker's diverticulum, it's not terribly common, but when they occur, it's an easily fixed entity. Okay, let's talk about varices. These pop up all the time. These are very common. They are, it's kind of sad when you see esophageal varices because you know this is really a secondary indication of something much worse, much more sinister happening. Esophageal varices, if you understand the portal venous system, have you all been lectured on the portal venous system, right? So you know about cirrhosis, you know about portal venous hypertension, and everything down or upline from the portal venous system, the pressure goes up. You have your rectal plexus, you have your periumbilical plexus, you have your esophageal plexus. Just like air in the tire in your car, if you put too much air in it, you'll get a bleb that sticks out the side of the tire. Well, that's what happens in esophageal varices. These folks, usually alcoholics, sometimes post-hepatitis C, cirrhotics, they get high venous pressures in their portal venous system. They get terrible hemorrhoids. You don't hear about it. But when they get esophageal varices, it's really bad. The common signs and symptoms, obviously bleeding. Endoscopy is the test of choice to see it. Endoscopists hate this. There's the portal venous system. You've all already been lectured on it. It doesn't do a good job at showing the rectal plexus or periumbilical plexus, but those are the keys in the esophageal plexus as well. All right, so what do we do about this? Endoscopic therapy. The GI doctors, when they go down an EGD and they see esophageal varices, they all vagal and get lightheaded because they hate them. You can't get by them. If you do get by them to look into the stomach, you wonder when one of those is going to rupture. When they do rupture, remember that it is your liver that produces your clotting factor. So if you have cirrhosis bad enough to have portal hypertension, your PT and PTT are way out. And so you have no factor 10, you have no 2, 5, and 7. And so if you do rupture these, they're high pressure, they're venous, and you have no clotting factor. So these people bleed to death, and some of them bleed to death right there, have the EGD. So it's scary. They can do endoscopic injections for singular ones. They do a little epinephrine on them. Sometimes they coagulate them, but they just hate to touch them. Complications, obviously bleeding. 50% stops spontaneously. The other 50%, it is brutal. So there's a picture of banded esophageal varices. Photocoagulation, injection, and banding is what we can do. If you just have, say, 3 little varices, take a chance, band them very quickly. You know, don't rush, but get them all 3 banded and breathe a sigh of relief. But in a month, he'll have 10 more. That person will have 10 more. So that is an option. Banding is, but still, it's really a harbinger of bad things to come. Okay, next big topic, gastritis, peptic ulcer disease. Think of them essentially one and the same. Gastritis is really the pre-peptic ulcer disease, so I kind of lectured them through one into the other. The idea is you treat the gastritis to avoid getting a peptic ulcer. That's the key. If you understand the pathophysiology of this, you'll have no problem. This is a busy slide. The idea here is know that the cardia of the stomach isn't the upper part, know that the duodenal bulb and pylorus is the bottom. If you understand this pathophysiology, you'll get all the questions. And it's simply that you have aggressive factors in your stomach, obviously. You have defensive factors that protect the wall of your stomach, obviously. As long as there's a balance of those two, everything works fine. But anything that tips that balance either way, you get problems. So if you decrease your defensive factors, you increase your aggressive factors, you'll get mucosal damage and an ulcer. So How's that come about? Well, this is a slide that's been around forever. It kind of gives you a list of defensive factors and aggressive factors. So starting from the left, the defensive factors, and I'll get into this a little bit more, but if you understand that you have a mucoid layer that covers the cells of the wall of your stomach, that mucus is key. As long as you make that mucus, and you also fill that mucus with bicarbonate, you have good blood flow to the cells, you have good cellular turnover, you produce growth factors in the wall of the stomach to get your cellular turnover, you'll have the cell renewal and you'll be good. Prostaglandin, the smallest box in blue there, that is the key player. Prostaglandin mediate, and there are several prostaglandins that do this, but the prostaglandins in the stomach mediate the production of the cell turnover. They mediate the production of the mucus, they mediate good blood flow, all of that. So those are the factors that really count for the protective side. Now the damaging side, there's a million of them, but these are the most important ones. Hydrochloric acid is obvious, okay? Pepsins, those are obvious, those are pancreatic enzymes, but the key is bile acids here on the right. I've seen it on a board exam. What is the most caustic substance that is either refluxed into the esophagus or causing peptic ulcer disease? It's bile acids, it's not hydrochloric acid. Okay, smoking and drinking, those obviously are aggressive factors to the stomach that doesn't like it. Now, ischemia, that's just the opposite over here that goes to blood flow, the protective side. If you have poor blood flow, that causes ischemia and hypoxia. So when you have somebody in the unit on the ventilator, we really protect their stomachs because we did great work keeping people alive in the 90s when they were on the ventilator, but we never handled the actual physiologic stress. And these people would perforate their stomachs right and left. They survived their pneumonia, they survived their heart attack, they didn't survive their perf stomach. So we realized everybody that goes to the unit gets IV Pepsin or IV Prilosec from the minute they get in there. So hypoxia and ischemia are real things to protect from. Last one's H. pylori. We'll discuss that because that's a topic I like to ask questions about. Again, it's all about the balance here. All right, so there's the mucus layer. That's all I want you to know about that slide. That yellow is the mucus layer. That's the key player in all this. So protective mechanisms. Obviously, you see your layers here. You have your mucosa, your submucosa, your muscularis propria, and your serosa. That's kind of inside to outside. You want to protect all layers, especially the mucosa. So, prostaglandin, the big player. Prostaglandin stimulates glycoprotein, which is the mucinous part of that mucoid layer, stimulates bicarbonate secretions, phospholipid secretions, enhancement of blood flow, cellular turnover, all the things we talked about, okay? Prostaglandins, protective effect, they're good. So what is it about non-steroidal anti-inflammatories that's so bad? Now, we'll get back to the prostaglandins, but the idea is people think, well, golly, aspirin, it's an acid, so it must directly irritate my stomach. That is not the effect of aspirin. Enteric-coating aspirin does very little. It sells, but it doesn't do a whole lot. So aspirin, I mean, you all know, aspirin inhibits cyclooxygenase and thromboxane A2. Well, those are two of the key enzymes in production of prostaglandins. They are both in the same pathway of prostaglandin synthesis. And so if aspirin inhibits those two enzymes, we don't get prostaglandin synthesis. And that's many prostaglandins. You know, some prostaglandins are involved in pain, some are involved in fever, some are involved in inflammation, and some are involved in good parts of making the mucus bilayer protected. So you don't get to pick what you inhibit. So when you take aspirin, you inhibit the protective layer of the stomach, causing a negative effect on all those things we just talked about. So here's a picture of post-aspirin use. Normal mucosa on the scanning electron micrograph on the right. It is allowing the aggressive factors to tear the cells down. But it's not the fact that aspirin is an acid. Okay, H. pylori, the lowest little box on that aggressive factor. They like this. This is an emerging topic. We now know just about everything there is to know about this little guy. He is a very aggressive, very fastidious, large organism. He is the ultimate hyperactive bacteria. He's ADHD to the max. We used to use Proteus vulgaris as the gold standard. Now this guy really is the active player. So it is both pro-aggressive and anti-defensive in the stomach. It cleaves urea to ammonia, and ammonia specifically and directly inhibits prostaglandin synthesis. So there's one side on the decreased defensive side. It also can burrow submucosally and stimulate parietal cells directly. So you produce more acid and you remove the defense, and so you end up with big ulcers with H. pylori. So when you have somebody with chronic reflux or chronic gastritis, PPIs, the day they stop them, their symptoms come back, check them for H. pylori. Now, the problem with H. pylori, again, it's the HD king in bacteria, so, that's what we just talked about there. So we've got to diagnose it, we've got to treat it, but it becomes resistant to a single antibiotic in 2 days. It becomes resistant to 2 antibiotics in 5 days. And so you have to really cover it up. You have to go after it in many different angles. You can diagnose it any one of these ways. It's easy. They're all sensitive, they're specific. The difference is which is more expensive and which is not, truly. You know, the aeration breath test is really inexpensive and used pretty widely. We use stool sample cultures, and that's pretty inexpensive, and it's very sensitive and specific. But you can diagnose this fairly simply. Okay, 90 to 100% of duodenal ulcer patients have H. pylori. Sounds like a pretty tight association to me, so there is more than likely a cause and effect there. Look at gastric ulcer, gastric cancer, dyspepsia, and even asymptomatic people. 20 to 45% of people, when they were tested in a wide study, had H. pylori. They didn't know it. Right, so how do we eradicate it? Here's a slide. You don't have to memorize this, but notice there's all these things that you can use, but they have to be used in combination. The key is you have to use a minimum of 3 antibiotics. You can use combinations of amoxicillin, clarithromycin, you tetracyclines, lots of things. So you use a minimum of 3 antibiotics. Now you have to go after their environment. You want to get their environment basic. You want to get rid of the acid. They love the acidic environment. So you put them on proton pump inhibitors and high doses. So it's Prilosec 20 BID or 40 BID. You want to get that pH up because they hate that. And then you can add things like Pepto-Bismol. H. pylori cannot stand to replicate in a bismuth-rich environment. So add Pepto-Bismol, put them on 3 antibiotics, get the proton pump inhibitors on twice the upper dose. And then you eradicate this. And the 5-year return is about 80%. So this is an ongoing problem, but it really causes enough morbidity and mortality that you need to treat this if you find it. Okay, Zoller-Jelson syndrome. We're talking again about gastritis and peptic ulcer disease. This is a rare thing. I've seen it one time in one patient, and the patient passed away. But the idea of this is you get a non-beta cell islet tumor. Maybe your beta cells is insulin glucagon. Non-beta islet cells can grow without the switch for stopping division on, and that is a gastrinoma. And they obviously it produces gastrin, unchecked production of gastrin. Gastrin is the direct secretory trigger for hydrochloric acid in the stomach. It tells you produce me some acid. Well, if you've got a little tumor in there that's telling you produce acid 24 hours a day, 7 days a week, and don't stop, clearly we're tipping that aggressive factor over, and these people get horrible multiple ulcers all over their stomach and have problems with that. Not to mention the fact that commonly 2/3 of these gastrinomas are malignant and they spread early. So Zoller-Jelson syndrome is a non-beta cell islet tumor that produces directly way too much acid, and they get peptic ulcers. That's the idea. It's very simple physiologically, no memorization there, it just makes sense. Okay, so let's move into peptic ulcer disease. We talked about gastritis, and we got to turn down the aggressive forces and build up our defensive forces. What if we don't? So we get a defect in the gastrointestinal mucosa, and it erodes. Now, again, this is autodigestion usually, but it doesn't just erode superficially. That's gastritis. We showed you the 3 or 4 layers there. It doesn't usually go through the serosa unless you rupture, but the idea is it's left unchecked, it's left untreated, you get whole erosions through all 3 layers. There's a picture of a gastric or peptic ulcer. You can see that that's going to be problems. That's probably in a resected part of the stomach with the ulcer in it. So the majority of them are 1 to 2 centimeters. Usually they're very small. Acid is necessary for ulcer development, but that's a statement called Schwartz's dictum. If you have no acid, you can't have an ulcer. Some people who've had vagotomies don't make acids, and if you find an ulcer, it's cancer 100% of the time. So for it to be a normal ulcer, you've got to have acid. So if you find an ulcer in somebody without acid, that's a cancer. All right, so clinical features, obviously, they get abdominal pain, they throw up blood, they can have dark stools, they get bright red blood directed if you have a massive bleed, but it takes a massive gastric bleed to get bright red blood below. So what are you going to do? Large bore IVs, get them fluid and electrolyte replenished, NG lavage, try and clear their stomach, and get a scope down there and see what you're dealing with. You may have to transfuse them at the same time you're dumping in normal saline, so the key is get them fluid and electrolytically balanced again first. Clinical features, just what we talked about, abdominal pain. Some of them spontaneously stop bleeding. Some have no pain at all, and you find ulcers in 40% of these people. So Smokers, obviously smokers, on any test question, yes, whatever it is, if the patient smokes, they have it, if it's bad. So smokers have a higher incidence of ulcer, more recurrences, more complications, more mortality, more morbidity, all of that. That's kind of a no-brainer. Complications we talked about, hemorrhage, okay, 15%, perforation, penetration, low rate, but still catastrophic event if it happens. So you really got to treat peptic ulcer disease, you got to treat gastritis before you get to peptic ulcer disease. Perforation, that's pretty obvious, rapid diagnosis. You have to know they're usually hypotensive, they're moving on to sepsis, and the mortality is about 20%. Here's a picture of the hemorrhage. Usually they'll, as long as they're not cirrhotic and they don't have a blood disorder, a clotting disorder, they'll usually kind of clot off on their own. These folks have liver disease, everybody's on aspirin now, now we've got the factor 10 inhibitors. These people bleed unit after unit after unit, and you just gotta put them in the hospital and check serial CBCs and hope it calms down. Because you can go in and photocoagulate that, but that ulcer, you don't know if that is only covered by the serosa. And if you just go in and zap, now you're looking at the backside of the stomach and the vagal nerve there, and you think, we're in trouble. All right. Diagnosis, gold standard, EGD. That makes sense. And we keep going over that. What do you diagnose with? What do you treat with? The gold standard for peptic ulcers, EGD. Now let's talk about hiatal hernias. Hiatal hernias are really common. I bet 10% of the people in here have them. You have to understand what a hiatal hernia is. It's simply pulling the cardia of the stomach and the lower esophageal sphincter up through the part of the crura, or the part of the hiatus of the diaphragm, into a position it's not supposed to be. There's type 1, 2, 3, and 4. That's not important. That's just how much is pulled up. Type 1 is this picture on the left. It is just a simple amount of the cardia pulled up, nothing more. Type 2, 3, and 4 depends on how much more the stomach is pulled up into a paraesophageal position. But the idea is if you pull that upper part of the stomach up there, above the diaphragm, that's a hiatal hernia. So why is that important? Well, remember, where are the cells that produce the majority of the acid? That's in that upper part of the stomach. So if I now have pulled that up to the diaphragm, and I may have kind of closed off the exit to that, I eat a meal, I'm producing acid, it's trapped in that room, we're going to get huge ulcers there and perforation. So you have to watch these people. They get gastritis and epigastric burning post-meal. Sometimes they have it all day long. And these are the folks that fail proton pump inhibition treatment. And so you EGD them and they say, oh, guess what? They have a giant hiatal hernia. Now, do we fix them? We can. But the mortality of fixing a hiatal hernia with the Nissen, it's a surgery that fixes it, it's really high. It's a huge intrathoracic and intra-abdominal surgery that takes a CT surgeon and a general surgeon. You know, the fix may be worse than the disease. The last person that insisted of mine on being fixed did not survive the surgery. And they were young. And I was like, I think you're, it's bad. So I have a big bias against fixing them. Unless you've got problems that are life-threatening. So anyway, hiatal hernia. You get damage to the esophageal membrane, allowing that part to climb up. That's type 1, 2, 3, and 4, obviously. The most common, 95%, are type 1, just the cardia pulled up there, that's it. So, the thing in there, obviously, marked erosions and ulcers within the hernia itself, that's because that's where you trap the acid. Okay? So how do we diagnose this? EGD, again, the gold standard. You can look right at it. Simple to do. You can do it quickly. It's not terribly invasive, so it's pretty well done. Plain films, they'll show a gas bubble. You'll see it on about 20% of your chest x-rays. They'll read out no acute chest disease, but instantly noted as a small hiatal hernia. You see it all the time. What do we do about it? PPI. PPI is the key. You can use Zantac or Tagamet. It works really well on symptoms, but again, it's not quite as good on endoscopic cellular repair. So it helps with the symptoms, but doesn't really fix the problem. PPIs really turn down the acid amount so you don't get as aggressive of ulcers in this. Surgical repair is reserved for the serious side effects of the ulcer itself. That's the Nissen fundoplication. It's a big surgery. You pull the stomach down, you wrap the cardia around the esophagus, and it locks it below the diaphragm. But you have to be in the chest, and you have to be in the abdomen at the same time. And physiologically, that's a big surgery. It's type 4 there. Okay. Pyloric stenosis. Next topic. We're getting toward the end here. You all have heard about it. You all may have seen it by now. It's pretty simple. It occurs 2 to 3.5 in 1,000 live births. It definitely has a male over female predilection. Why does it happen? We don't know. There's an association with giving kids macrolide antibiotics at birth. It's usually before 2 weeks of age, but we used to give them a dose of macrolide antibiotics if the mom was group B strep positive. We stopped doing that. We just treat the mom. Sorry about that. There's possibly a genetic predisposition. It barely rides above just flipping a coin for people that have had it, runs in families, but we haven't proven it yet. Again, the etiology is unknown. So classic presentation, projectile vomiting, 3 to 6 week infant. It's usually immediately post-prandial, whether it's breastfed, bottle fed, they're just fine. They feed, they look at you, and it is not spitting out. I mean, this is, you got a duck, and once you've seen it once, you'll never forget it, because it comes out as a tennis ball bolus. And you think, man, that kid's got great abs. And the kid looks great. They kind of look around like, what the hell? And then they'll cry a little bit because they didn't get any. Their mom's screaming, kids screaming. It's a real scene. The kids over time, because they're hungry. Now that you refeed them. And they grow up again. And so you refeed them, and the mom feels bad because she thinks she's failing. And so she feeds them half. And feeds them the other half, and they do it again. So they get emaciated, they get clinically dehydrated. These kids can get really sick because it's just a fact. Moms and dads tend to feel like, well, we're failing, we'll just keep trying to feed, so they wait 5 or 6 days, and the child really has gotten very little nutrition. They bring him in, the child's listless, laying there and moaning, and they tell you that story. So you've got to do something quickly. So it's common to get hypochloremic metabolic alkalosis because they're losing all of their hydrogen ion on the wall. And so they're trying to keep up with it, they get metabolically alkalotic. You have to really correct fluid and electrolyte disorders in anything in medicine. Correct fluid and electrolyte disorders before you operate on anybody. All right, so how do you diagnose this? This has gone back and forth. You don't want to CAT scan a newborn baby, abdominal ultrasound, but the problem is you have to have a good tertiary center that has a good pediatric ultrasound. And if they do, they can see the olive, that thing in the bottom right corner. You can see that big thick wall on that thing below the bubble. That big thick wall shouldn't be there. That should be the thin wall of the pylorus going out there. The ultrasound in a good center is 96% sensitive and 98% specific. So it does a good job at ruling in the disease and ruling out other things. Upper GI series, barium swallow have been used, but you give the kid barium before you can x-ray it all over the wall. So the main thing is abdominal ultrasound in a good center. So what do you do? So there's some good barium swallow. You can just see that thickened wall there, those 2 arrows are, and the canal is tiny. These kids dilate their stomachs and can't get rid of it. Okay, so pylorotomy, how do you fix it? The Heller pylorotomy is what's used in this. It's a pretty simple surgery. You go down to it, you open it transverse and close it sagittally, and it fixes it. It takes an elongated portion of the duodenum, it takes a part of the proximal duodenum and puts it together with the pylorus and makes a short little stubby ball. And these kids do well. Here's the pylorotomy, kind of, you see it there, the first 2 slides in A. Just foreshortens that very proximal duodenal area there into a little bulb. And these kids do fine, they never have a problem later on in life. There were some studies about 8 or 9 years ago where they tried other things. They said, let's stop operating on these kids. Let's dilate them, let's give them medicine, let's Botox that dude. Because you know, Botox fixes everything. Everybody's pretty, migraine headaches go away, cancer's cured, and you fix this. No, babies died from doing that, and so people stopped doing it. And then they tried to study for a while on conservative management. Let's just watch these kids. Let's give that a shot. Let's give them a week or 2. Babies died. So that's, balloon dilation doesn't really address the problem. Atropine injections of Botox doesn't really work. And then conservative management, you got to have a backup employment plan because you will be sued right out of practice. Okay, so that's the end of the proximal alimentary canal. Hopefully, yeah, I got you all out early. So questions on that? And just everything you really need is kind of in there. Really sit on the colored statements there. What's the gold standard for diagnosis? Understand physiology. And in any lecture, when you guys are going through school, it's important to ask why. When you're with me, whoever comes with me, I'll ask you why 100 times. That doesn't mean you'll have to know the exact right answer, but what I want you to think of is how pathophysiologically whatever is going on would be helpful or harmful, and why is it happening? What is hypertension? What's renal artery stenosis? What is pyloric stenosis? Why did this occur? And I'm telling you, 90% of the time, we'll go over it pathophysiologically, and you won't memorize it. It's not about writing stuff down on a card or getting stuff on your iPhone or downloading an app where you can type in 5 symptoms and that'll tell you what the diagnosis is. Don't do that. I've had PA students from all over the U.S. and they love that. I mean, they like to phone in their answers. The difference in this program run by Dr. McNeil is that you guys understand it and you know it and you can speak it. It's not a phone-in program where you just memorize things and you kind of, you close your eyes and you go, it's A, B, C, D. And you say, no, why? And so, that's why I try to set that lecture up like that. This happens because of this pathophysiologic mechanism, and if it were normal, it would happen this way. And if you all kind of study that way in every one of your subjects except psychiatry, which doesn't make any sense. Study about this stuff, you'll get all the questions, you'll do well. All right? Very good. Thank you guys.
Thank you.